So the next phase, or the next type of questions you can use during your debriefing is something called self-reflection or plus delta. And this is an idea, building on what Dave was saying, that you really want to try and maximize the amount of debriefing the participants do on themselves. And so you really want them to try and generate the learning objectives, to generate through reflection what they could do differently next time. And so when we think back to Kolb's learning cycle right there, that reflective component, we're trying to activate the brain. Why this is important is that we know that we actually learn better if we generate our own feedback for ourselves rather than someone tells us. And the classic example of this is think about your parents or your wife telling you to do something and how often that actually sticks, right? Not very often, right? But when you go through something yourself and you discover that you made a mistake and that there's something you could do differently to optimize it, you're much more likely to integrate it in the future. And so plus delta is, the plus is something that students did very well or a participant did very well, and the delta is what they would do differently next time. And I'll use either or both, either in conjunction or separately. So if there was a situation where the case really went quite poorly, and the learner very much struggled with the level of the simulation, or they missed the diagnosis, and you could really see them kind of self-destructing or in that cycle. I think we've all maybe seen a learner where they're kind of caught in that phase, or even in real life where you've been in a case where you just don't know what's going on and it's a bit overwhelming. I find that what you did well is a nice way of bigging up that person, or like Dave was saying, pumping up the tires, because you don't want the participants to leave from this feeling ultimately discouraged. And there's already some evidence that with very junior learners, if the patient experiences a bad outcome in simulation and they perceive that to be their fault, there's actually a lasting negativity on their performance in real life and in simulation for up to a year afterwards. So it is important that they leave with a sense of what they did well and what they're empowered to do better. The delta part might be something where you can push learners who actually did a very refined or excellent level for the ground level objectives. You could push them to what could they do differently for next time to take them to the next level. And so it's important in the plus delta because it allows you to see what are the objectives that the learners themselves are generating. And you can then realign them to say, okay, I was going to talk about these three things. The learners themselves have generated these two objectives that actually overlap with these two. So let's let them allow us to explore these issues first so that they're debriefing themselves before moving on to the kind of final objective I had that might have been a bit different. I'm going to let Dave talk about the third form of feedback focused advocacy inquiry, focused facilitation.
Great. So, in this analysis phase, we're debriefing. We've done directive feedback or considered directive feedback. Maybe we've considered plus delta. Advocacy inquiry is the third model of debriefing or facilitation that we want to talk about. Advocacy of inquiry is really about taking the facilitator's perception, observation, and point of view, and then reflecting it back to the learner and asking what their perspective was. So advocacy, if I'm the facilitator, would be my perspective, and inquiry is asking what the learner's perspective was. So this is really trying to create a two-way conversation. So in terms of this 2x2 box, if we have a low advocacy, low inquiry conversation, that means really no one's talking. Where a high advocacy and low inquiry conversation, it's really about explaining or imposing, and that's more directive feedback. Where high inquiry and low advocacy would be really about getting more information from the learner and less from the facilitator. So an example might be something like if I were running a simulation where there's a patient with congestive heart failure, atrial fibrillation, and hypotension. And I can see that the learner is in a bit of analysis paralysis, or what I would call it. They just can't decide what to do. Should I give them IV fluids? Should I synchronize cardiovert them? Should I give them pressors of some sort, for example? So I might say something like, I noticed there was a moment where you were having trouble making a decision. It seemed to me that you were really struggling with which treatment avenue to go down. Can you explain to me what was going on in your mind at that time? And so they might say, so that's the advocacy part. I'm saying, I noticed that I saw you struggling to make a decision. It seemed like you weren't really sure which pathway to go down. Tell me what was going on for you in that moment. And I'm inquiring what their perspective is. This creates a really two-way street of not, I saw that you let the patient be hypotensive for 20 minutes and did nothing. It's, I noticed what was going on and that seemed challenging. Tell me more about that for you. And this gives the learner an opportunity to say, you know, I really thought that I should cardiovert them, but I wasn't 100% sure that they were unstable. It allows us to pull out some of what their thought process is and their thinking is in a really two-way street. Advocacy inquiry is a more challenging, I find, in terms of how to facilitate, but is probably very effective in your more senior learners, and especially in interdisciplinary situations where, you know, I don't understand a nursing perspective or an RT perspective. So to get that learner's perspective, and these are some example questions where that you could ask whoever you're facilitating. How did you see it? What were your thoughts at that time? What were your priorities? I think advocacy inquiry is a great tool when you see a moment in simulation, which is a really challenging moment for that learner. If you see them pausing, not sure what to do, spinning their wheels, making a decision that they aren't sure about, to highlight that moment and say, hey, in that moment, I saw you struggling or having a challenge. Tell me what was going on. And advocacy inquiry is really great in those moments.
Yeah, I really like it in the interprofessional departments as well, where there's a variation in clinical decision making. And so there's multiple different pathways that this patient could be treated. You know, to Dave's example, you could cardiovert, you could digload, you could give fluid, you could, you know, there's so many different pathways that could conceivably be right. And sometimes this is helpful to uncover what was the participant actually thinking about, and it actually enriches the learning. The important part here is that you're making explicit your point of view first. So it lowers the stake. And one of the key things that took me a while to understand in this is that it's allowing you to remove that element of pimping or that guess what I'm thinking, which is, I think, one of the most scary elements of being a teacher. And I remember when I transitioned from a resident to a staff, I really struggled with how do you phrase a question in a way that the learner doesn't sit there and say, well, I know there's 5 possible answers, but which one of the 5 does he actually want? And they end up focusing on what they think you want to hear rather than what perspective is going on. So AI is definitely the highest sort of complexity to do, but offers the richest information back. So I think it's something that we'll practice today, but will definitely require serial practicing for you as you move forward.
Can I just jump in there? And I think that when we're practicing advocacy inquiry, I really encourage people to think about what types of questions they're comfortable asking. Because some of those, if you can go back one slide there, Aline, I find for me are confrontational almost. What were you thinking? I can say that the right way, or I can say, what were you thinking? So I think that for some of us, I try to script it where I feel most comfortable in a non-judgmental way, to inquire genuinely what a participant or learner was doing or thinking at that time. And so I think Aline's point of let's practice this, but also if you're a more inexperienced facilitator, and as you gain experience, to script some of those questions for yourself about what works for you in terms of how you inquire into people's thought process.
Yeah, that's an excellent point. I think that's why the "what were you thinking" was in italics there, because as I was writing it, I could hear my wife's voice in the background, and I was like, oh no. So I like to wrap up my debrief with takeout, right? And so I go around the room for every participant, and I ask them for one thing that they're going to take away from this scenario. So what's one thing they're going to either do again next time or do differently the next time they have a sick patient? What this helps me do is that it makes sure that there's a high level of engagement from the audience. It makes sure that people can, from all the discussion that was there, distill it down into one concrete thing that they can walk away with. So they can say, in this case, I learned this. And I find it's a natural transition towards the end of the scenario. If you're feeling like making it more challenging for your participants, you can make it that there's no repeats, which always makes it very interesting as you get kind of further along and people take the easy ones of like use closed loop communication and like we should have a leader. And then as you get kind of further in, you can pull out some nuanced details. And this is also really helpful for experienced providers if you're looking for latent safety threats or trying to teach something like a new protocol. So putting this together, we talked about setting the scene initially with our pre-brief and really setting our objectives and our goal for bringing everyone together. We talked about the reactions phase and allowing those emotions to kind of percolate and getting early participation from your in responses. We talked about the description phase being that explanation of the case, which can be omitted if you feel like everyone was kind of on the same page already, but is very useful in scenarios where people were outside the room or may have missed some. We broke down the analysis even further into performance domains that we could explore and went through some of the different elements there, and then talked about 3 different techniques we could use within the analysis phase: the directive, the self plus delta, and the focused facilitation or advocacy inquiry model. And the last one is application or summary, which was the takeaways that we talked about, which could either be learner-centric, like we discussed, where the learners give it to you, or could be instructor-centered. So if you have something on your objective list that they didn't really say, you could say, the point of this case was really to teach you to do a protected intubation, or etc. What we're going to do now is we're going to go into breakout groups. So I'm going to ask Catherine and Jen to distribute us, and then we'll get a chance to practice and ask questions.
So we should probably give people a chance to ask questions right now. While you were talking, guys, I noticed that in the link with the picture of the Pearls framework, they use slightly different terms. So I just wanted to make sure everyone understands that on the page where it says 3 approaches, learner self-assessment is basically synonymous with plus delta. Focused facilitation is another way of saying advocacy inquiry. And provide information is another way of saying directive, just so that we're all on the same page. And then you can see sample phrases that you can use there. Is there any burning questions at this moment before we split into groups? Okay, so we are going to have a 45-minute small group work. There will be either 5 or 6 participants per group, and everyone will get a chance to debrief. We're all going to have a chance, so please volunteer early rather than later. is what and then after the breakout, when we come back to the big group, we will have a couple of minutes of break. So I'll put on the side here in the chat until which time that we will have the slideshow resumed or the large group session resumed.
So any thoughts for the big group from our smaller groups? Does anyone want to chat about what they talked about, or any questions that emerged, or any big ideas or discoveries, epiphanies, revelations?
What I found was the 3 analysis question, the AI, delta plus. I mean, that's just a stepping stone to get the discussion started, right? But then you have to kind of fill it with experience and stuff. You have to know how to carry on that conversation a little bit further. Because if you just were to ask those questions and the learner would reply to them, and if you finish the conversation at that point, then you wouldn't get as much out of the sim as you would if you continued with that discussion forward and use that as a stepping stone.
For sure, Ali, that's a really good point. This is the introductory framework, and then as you practice this in simulation, you'll see the real skill is kind of stringing things together. We had a nice conversation in our group where Krista demonstrated some really mastery level ability to just like blend 3 phases together, and I was like, oh man, you're in the advanced class. Really the next step is how do you bring these together into real life and transition between different moments, and there are some strategies around how to do that over time. So some good comments. Any other thoughts? No? All right. We're going to transition a little bit into talking about some common situations that you may encounter in your early debriefing days, namely the challenging debrief, specifically because of sort of some challenging personalities who may be in that room. I think watching that video with Newman, it's funny, our group was like, we know Newman. We've worked with Newman before. Right? I think lots of us have seen that kind of personality before. And so we wanted to kind of talk about and show and sort of role model some of the strategies for managing different types of learners in this situation. So Dave,
great.
I think
thanks, Liam. So these are a couple of types of learners that you might or participants you might encounter, right? The overconfident learner, the silent learner, the overly self-critical learner, and you might get at different phases of learning. You might get these. So what we were going to model a little bit was we're going to take the video of Newman that I think everyone watched, Dr. Newman, and I will first play the role of overconfident learner, and Alim will debrief me a little bit, and we can role model some of the strategies of using challenge and debrief, of how to get get through to some of these learners and with some strategies. Sound fair, Alim?
Sounds good. So we'll start right after the scenario kind of ended. We'll kind of open up with our pre-briefing phrase like we talked about. So we'll talk about how this is a safe space and comfortable, and then we'll kind of get right into it and fast forward a few minutes into the debrief and kind of pick in on a moment that I think we can all recall, which was sort of Newman's lack of closed-loop communication around administering sedatives prior to intubation. So he doesn't really give kind of clear orders there. He kind of barks things around, and we'll kind of zoom into that moment. So, Dr. Newman, I'm just thinking about a moment I saw, which was kind of that preparation for intubation phase right beforehand with the medications. I noticed there were some challenges there. Can you walk me through what was happening at that time?
Yeah, I think we all knew that the patient needed to be intubated, and so I said they need intubation drugs. They got them. They got intubated. Mission accomplished from my perspective.
Okay, yeah, and you're right that at the end we were able to get the patient successfully intubated. My concern is that I noticed there was a moment of confusion where it wasn't clear if the patient had received the drugs or not. So I noticed that you had asked for a medication. It was unclear that it was given. My concern is that if you start the intubation process prior to the administration of paralytics and inductions, your first pass success would decrease. What was going through your mind at that time?
Yeah, what was going through my mind was patient needs to be intubated, and, I think for my level, I think it was really awesome, to be honest. I think they got intubated, and that was the only goal. Like, I feel like these simulations, they're just so artificial, and really what matters at the end of the day, I got them intubated. So I don't understand what you're even trying to ask me.
Yeah, and it's a fair point that, there is a bit of suspension of disbelief that has to happen, right? Mr. Jones wasn't a very convincing old man. But one of the things that are also important in these circumstances is the use of closed-loop communication. I'd like to engage Hina, the nurse, and get her thoughts on what was the communication like around the time of intubation. And so I'd rope in Hina to give some perspective as well on her thoughts on it. And so Hina tells us about how she felt like some of the orders were unclear. So thank you, Hina. It sounds like you mentioned that there was... It sounds like, you thought that there were some areas where the communication was maybe a little unclear. Dr. Newman, when you're thinking about the orders you were giving, can you think of a way that next time you could phrase them in a manner that might be a little bit more clear, or that could mitigate some of the confusion that was present today?
Yeah, we keep talking about closed loop communication. I guess that's what I'm supposed to do. So I guess, I'm hearing from Hina that I didn't do that. From my perspective, that's a nurse's job, but I think that I guess the next time I can say, this is what I want, tell me when it's done. Is that what I'm supposed to say? Yeah,
I think that's a good point, Newman. You bring up a point about role clarity, right? Like you were saying that certain things were nurses' jobs, certain things were physician jobs. And I just want to pick up on that thread a little bit more. What do you think your role was as team leader there?
Yeah, I don't think that I was really the team leader. I think I was the intubator, right? That's my job. Intubate the patient. And I did it. We keep coming back to this, but I did it. So I think it was great.
Okay, that's great. So from a task perspective, you were able to successfully complete the task. So that's good. And the technical component was well done. What we're trying to do is zoom out a little bit and look at some of the behaviors around intubation, because that's a high risk scenario, as we all kind of know. And there was some concerns and frustration in the team that we could see. And we want to pull that out a little bit. Thinking about the cognitive elements of intubation, can you talk us through what were some of the cognitive elements that you explored prior to intubation? So not the technical ones, the cognitive ones.
Sure. Maybe I'll pause us there just in the interest of time.
Yeah.
Someone's complimenting you for not laying the smackdown on me, which is good. I think some of the strategies that Alim was using on me as the overconfident learner were super awesome. I think that the overconfident learner, I think a couple of things I really liked that you did, Alim, was one is rope in other people, right? It's much harder to be overconfident when you get direct feedback on something specific from other team members. That being said, often team members are apprehensive to provide critical feedback to a bully, right? And the other thing I liked that you did, Alim, was got me to do something specific, right? So on the closed loop communications, you went from general questioning in general insights to more specific insight. So to say, okay, let's take this moment about orders. Tell me how you gave those orders. Give me an example of how you might give the orders the next time. So it's directive feedback, plus how you would change things in the future with very specific examples. And I think that can get the overconfident or the lack of insight learner to be very practical and specific about where those gaps were. Were there other things in particular you were trying, Aline?
Yeah, I think the other thing is I was trying to role model some AI level questions there. And the purpose of those was to get a sense of the frame. So it was interesting in our conversation that you as Dr. Newman were kind of alluding to the fact that you saw your role as a technical role. You saw your role as an intubator, right? And so that's more of a technical rather than a cognitive role. And that may explain some of your behavior because you felt like the rest of the team should do their technical tasks and that you actually didn't identify as the team leader, which is actually very interesting from a debriefing point of view that you didn't see yourself in that role even though you were playing that role. And that dissonance is actually a very interesting performance gap to explore. So I think it's helpful that when you're approaching these scenarios, without, we talked about this in our small group a little bit, but instead of me ascribing a frame to you, instead of me writing a narrative that Newman is kind of a jerk, if I actually let Newman explain why he did what he did while describing specific incidences that I observed and my understanding or my interpretation of why those events could have been dangerous, it allows for a really rich understanding of your perspective behind the learner. Remember that overconfidence is sometimes seen as a self-defense mechanism as well for fear, right? And we know that bullies sometimes act from a position of insecurity and fear themselves. And going at them directly is very rarely a fruitful strategy because it usually creates conflict, creates animosity, and sort of escalates further. And so to reiterate some of the techniques we used were pulling in other people to see if we could achieve consensus, using specificity, and trying to understand their perspective. I'd say those were the three techniques that I used in that circumstance.
And I think that the other comment you made there, Aline, is very valid, is what's the learner's frame? Because if the learner's frame was, this scenario was about, could I intubate the patient? And I think you got the learner to try to reorient their frame.
And that's a good, that might be also good feedback on how you created the scenario, right? Because if they walked in and said, oh, this was a technical task, my job is to put the tube in the hole, and they walked out and said, high fives, high fives, high fives, laryngoscope drop, right? Then maybe you didn't write the scenario in a way that made them understand that there was actually more objectives behind that. And in the debriefing, that might be somewhere where you could actually explicitly say the objectives of this scenario were not just intubation, but were also crisis resource management skills like closed loop communication. Let's explore that in more detail. So it's okay for you to take a more facilitator-centric approach to debriefing at that point and say, these are the objectives I want us to explore in a little bit more detail.